I'm Dr. Gary Hoffman, a member of our Department of Rheumatic and Immunologic Diseases and founder of our Center for Vasculitis Care and Research. I welcome this opportunity to come to you outside of the context of the usual classroom to speak to you about vasculitis. I'd like to start by just introducing you to the concept of vasculitis in the simplest of terms, so no one in the viewing audience is left behind. And to do that in the simplest way, I would say that as you think about vasculitis, think about the trafficking of white blood cells within the circulatory system and how it's done right and how it can get messed up. And in messing it up, one of the ways that it can get messed up is to produce injury to the vessels, the conduits that are carrying these cells, and that injury we call vasculitis. Now, you all know that the circulatory system arborizes, if you will, like a tree, and that the areas of exchange as materials go through the circulation is most effective at the level of the smallest blood vessels, the capillaries and postcapillary venules. So that's where most of the action takes place. And if you would oblige me by accepting my feeble artwork here, this cartoon of a blood vessel and the cells within the circulation, you can imagine that for exchange of chemicals and nutrients to take place, that would be very difficult if it were going to take place throughout the wall of a muscular vessel to get access into tissue. In fact, that doesn't happen. So the nutrients that are carried in here are available to the most superficial cells, the endothelial cells, and maybe a few of the superficial muscular cells. But where most of the nutrition for the vessel takes place is through these cells within the adventitia, the outer layer, the vasa vasorum. So getting cells or nutrients from the circulation into the tissue is not carried out within these muscular arteries, carried out at the level of capillaries and postcapillary venules. So here's a capillary, here's a postcapillary venule. You can see they are only one cell layer thick. So if you were a white cell that was involved in immune surveillance and you needed to get out of the vessel to go and seek and destroy danger signals within the tissue, you would find it most convenient to get through the wall of these single cell, very thin vessels and not the muscular arteries. And of course, the same is true for nutritional exchange and waste exchange. So here in this scanning EM, you can see a white blood cell under normal circumstances going through the junctions between endothelial cells lining the blood vessel, squeezing through these junctions, going out into the tissue, and under normal circumstances doing no harm whatsoever. The vessel wall remains intact during normal white cell trafficking. So how does this happen? What orchestrates these movements within these smallest blood vessels? Well, the first stage in transmigration of white blood cells into tissue is what we call rolling of the white blood cells along the lining of the smallest vessels, the capillaries and postcapillary venules. And if there's a signal of injury that's significant enough, then the white blood cells will bind more tightly to those endothelial cells, and in binding more tightly will take the first step towards transmigration into the tissue, transmigration through these endothelial cell junctures. So what is it that calls the white blood cells outside of this microcirculatory environment? What is it that's calling it out of the circulation into the tissues? Well, it's the nature of the injury. It's, if you will, the antigens that are produced, and also the chemokines that are produced by the tissue and perhaps by the antigenic agent itself within the tissue. So again, this is one of my cartoons here of the circulatory system and the blood within the vessel. Here is the basement membrane, and picture the tissue itself that's being fed by the blood out here. And with injury, an injury that's adequate enough to elicit a response from endothelial cells and white blood cells, there is upregulation of molecules on the surface of these cells. On the endothelial cells, there are endothelial selectins or E-selectins. On the white blood cells, there are leukocyte selectins or L-selectins. And these, the endothelial cell and leukocyte selectins, are docking ports for each other. So given injury, there is going to be at least loose binding through these cells. Now, if the injury is significant enough, there will be a number of mediators that are produced, and these mediators will enhance the chemical reactive process so that on the surface of the activated white blood cells, we see the production now of beta-2 integrins. LFA and MAC1 are two examples. And on the surface of the endothelial cells, there's upregulation of additional Velcro-like particles here within the family of the immunoglobulin supergene family. And one example of that would be ICAM1, or intercellular adhesion molecule 1. And this leads to more tight binding that sets the stage for transmigration. So what white cell migrates and what does not migrate is determined, as I said before, by the nature of the trigger, the antigen, the source of injury, and the response that it elicits within the damaged tissue. So say, for example, within a particular tissue, the injurious agent is a parasite. And that parasite, either itself or because of the nature of the injury, produces the chemokine eotaxin or IL-5. So the call here then is for eosinophils to come through because of this very specific chemokine response to injury. Now, what if, on the other hand, the injurious agent was a virus or a fungus or a mycobacteria? Then the predominant chemokine that's produced is monocyte chemoattractant protein 1, IP10, or RANTES, and here the call is for monocytes to transmigrate. Now, if there was predominantly IL-8 produced by a bacterial antigen such as staph or strep, that would be a setting in which IL-8 was produced and neutrophils would come through. Now, this makes it seem all very simple, but in fact, it's not, because the playing field changes as time beyond the initial injury changes. So what might initially be a monocyte response may change later to primarily a fibroblastic proliferative response. What may initially be a neutrophilic response, often as injury is repaired and cleared, there is increasing numbers of mononuclear cells that come into the territory. And sometimes you see a little bit of everything, and there's a mixed cellular infiltrate. So this is all very carefully orchestrated. The movement of cells through the vessel wall in health does not produce injury. But when those inflammatory cells get caught up within the vessel wall, dump their toxic loads, not just to protect you, but dump their toxic loads in a way that is pathological, that is maladaptive, those toxic materials will then lead to damage of the vessel wall, and that is what we call vasculitis. So remember, transmigration occurs only at the level normally of capillaries and venules. And if we were to see clusters of white blood cells within the wall of a muscular artery, that is always abnormal. That's always vasculitis, even if the wall is not necrotic. You should not see clusters of white blood cells within muscular arteries, such as in this cartoon here. So here I've drawn in some white blood cells within the vessel wall, and the question then becomes, why are they there? And one of the reasons that they can be there is because of perhaps an infectious agent lodging within the vessel wall and triggering a response that is not maladaptive but is adaptive. There's a bacteria, perhaps a fungus within the vessel wall. There's a normal immune response to get to that, but then there's collateral damage that involves the vessel wall itself. So that's a secondary form of vasculitis related to infectious agents. But in most forms of vasculitis, we don't know what the underlying cause is, and we classify those forms of vasculitis based upon what we think we understand about mechanisms such as immune complexes being present in the site of injury, or direct antibody-mediated cell injuries, such as in Goodpasture's disease. Very often, we're dealing with cell-mediated mechanisms, as in giant cell arteritis or Takayasu's, but oftentimes there's multiple players that come to the playing field that are the mediators of injury. Now, the other point that I wanted to make before we get into very specific discussion about types of vasculitis is when you look at the microvasculature of any organ whatsoever, whether it's the heart or the gut or any solid organ, that microvasculature is very different in one organ compared to the next. And in fact, what developmental biologists and embryologists will tell you, which is just everyday knowledge to them, but is not everyday knowledge to most clinicians, is that the macro and microvascular beds within each organ are as unique and different as the parenchyma within those organs themselves. And it's those differences within the microvasculature that probably are very important and are very poorly understood in terms of what makes certain organs vulnerable and certain organs not vulnerable in different forms of vasculitis. Now let's transition from there to the notion of primary and secondary vasculitis. I've already alluded to this. Primary is a reflection of our ignorance. We don't know what the cause is, so we call it primary idiopathic. In most cases, we assume that it's autoimmune, whereas secondary is we do know the cause of the vascular injury, and so we call it vasculitis due to staph or strep or hepatitis. Those would all be secondary. So let me give you some examples to think about in distinguishing primary and secondary, and we'll start with this case. So this is a 54-year-old woman who presents with a 2-day history of this rash, which is painful, plaque-like, necrotic, And it's not only on her face and ears, which should be a big tip-off right here to diagnosis, because this is a very unusual place to get vasculitis. Also on the breasts and extremities. She has no other complaints. This is principally a cutaneous skin presentation. So you get some lab tests, and you find that she's neutropenic, low white count, lymphopenic, and she has a bunch of antibodies. She even has positive ANCA by indirect immunofluorescence, and it's positive and showing both a perinuclear as well as a cytoplasmic pattern. And by ELISA, you know the antibody is directed to proteinase 3. So those of you who have seen this before will know immediately what the diagnosis is because of this particular pattern. Those of you who haven't seen it, unless you are an extraordinary reader in terms of the breadth and depth of what you read, probably won't get this. But for those of you who might know, I would ask, what is the most likely diagnosis? And for those of you who don't know, I'll make this multiple choice. So could this be granulomatosis and polyangiitis, which is the new name we have given to Wegener's granulomatosis? She's ANCA positive, maybe that's the tip-off there. Could it be microscopic polyangiitis, or MPA? Could it be antiphospholipid antibody syndrome? Could it be a form of vasculopathy that's associated with the use of vasoconstricting agents and levamisole? Could it be disseminated intravascular coagulopathy? And so here I give you another picture of a man with this similar form of vascular injury, again with ear involvement. And so the additional data that has been obtained to confirm the diagnosis is a tox screen, which turns out to be positive for cocaine, opiates, and levamisole. And so this is someone who's been abusing cocaine, and that cocaine has been laced with levamisole. The skin biopsy, very interestingly, shows fibrin deposition within the vessel, vasculopathy, and this is what we'd call a pseudovasculitis. But I would emphasize that with cocaine and levamisole, you can get real vasculitis as well. The patient's treated with IV methylprednisolone and then later oral prednisone, and it's of no benefit whatsoever. Now, I would just add to that, in other cases, there is some modest benefit with the use of steroids, but in this case, there wasn't any. So this is cocaine, levamisole, vasculopathy, could be vasculitis, and the only treatment for it that will stop these lesions is to stop using cocaine and levamisole. Now, just to give you a sense of how this is something likely to be seen by you. Perhaps you've already seen it and didn't recognize it and didn't make the diagnosis. But it is not rare. Just think about the number of people in the world who have used cocaine, upwards of 20 million people worldwide, cocaine users. And then think about, just in America, that over 10% of our population, 38 million Americans at some time, have used cocaine in their lives, and a significant percent of those people are chronic users. Those are the people who are more likely to get this. Now, what about the levamisole story? Actually, levamisole is a very interesting drug. It's been used in many different settings. It's an antihelminthic. It has anti-inflammatory properties, and because of that, it has been used in diseases such as rheumatoid arthritis. It also has anti-cancer properties, so it's been used to treat colon cancer. It's even been used for its anti-inflammatory properties in pediatric nephrotic syndrome. And it's from this experience not with cocaine, that we know that levamisole by itself can produce many of the characteristics that I just told you about and showed you in those patient pictures. So levamisole is added to about 70% of all cocaine that's distributed in the United States. And we know that from government agency data. And we know from this prior experience where it was used, no longer used, for medical indications, that this drug by itself can account for neutropenia, agranulocytosis, thrombocytopenia, skin ulcers and rashes, vasculitis, thrombosis, convulsions, hypogammaglobulinemia, arthritis, arthralgias, multifocal leukoencephalopathy, and the production of many, many autoantibodies. So it is an agent that causes dysregulation of many normal immunologic functions. So when do you consider cocaine and levamisole? Certainly when you see these plaque-like necrotic lesions, when you see lesions in the ears like I showed you, and when these vaso-occlusive manifestations are associated with a large number of different types of autoantibodies that don't necessarily fit any rheumatologic disease. So I show you these references at the bottom of the slide also to point out that this has been discussed in abundance in the recent literature. It's out there. Perhaps you didn't focus on it because you didn't have a patient that had features like this or in whom you were aware of cocaine use that drew you to that article, but hopefully you're aware of it now and you might make the diagnosis next time you see someone like this. Now, there are a variety of other kinds of secondary forms of vasculitis that may not improve at all with corticosteroids and other immunosuppressive agents, or may improve minimally and the disease persists. So I'll give you a couple of examples of patients like that that have come to me as a consultant. So here we see someone with the hand deformities and foot deformities of rheumatoid arthritis. And we see these small palpable purpuric lesions, and the referring doctor said, well, yeah, my patient with rheumatoid arthritis has now developed rheumatoid vasculitis. Well, only the subtext to this case is that this patient has been treated over-aggressively with methotrexate and azathioprine and steroids over the years. The patient's arthritis seemed to be quiescent, so the practitioner was pleased with the response. And when this patient then presents with fever, a new heart murmur, and this rash, and even though the rash is biopsied and shows small vessel vasculitis, when this patient was referred to us 24 hours later, he died in our hospital because of the cause of this rash, this murmur being due to endocarditis, staphylococcal endocarditis, and not vasculitis due to rheumatoid arthritis. So secondary vasculitis, yes, it can occur in rheumatoid arthritis. It can be due to rheumatoid arthritis, but also can be a manifestation of endocarditis, and in this case, in a patient who was profoundly immunosuppressed. This patient was sent to us. He's a heavyset, middle-aged male, but nonetheless, he was sent to us because he had already lost a significant amount of weight. He had unrelenting fevers and lymphadenopathy. His doctor biopsied this rash and demonstrated that there was small vessel vasculitis within these lesions. He treated him with 60 milligrams of prednisone a day. He did not improve. Well, you all probably can guess that isolated cutaneous vasculitis often responds dramatically to steroids, but this fellow didn't improve at all. So there's a big red flag there. Why isn't he improving? What is this antigen that's not being cleared? What is this immune response that can't be controlled? And so what subsequently we found out was this man's lymphadenopathy was related to a non-Hodgkin's lymphoma. And when we treated the lymphoma for this paraneoplastic form of vasculitis, the rash, the vasculitic rash, resolved. This was a patient we were called to see from our surgical service. The patient had had a surgical procedure the week before. As you can see, he was quite elderly, and a week after his surgical procedure, he developed this rash, which we would describe as a livedo reticularis, cyanotic toes, and you should not only be able to guess what this rash represents, but also what was his surgical procedure. I'll give you just a moment to think about that. It is a vasculitic rash, and a biopsy was done. And what we found within that vasculitic lesion were the ghosts of cholesterol emboli. So his operation was a abdominal aortic aneurysm repair. That aneurysm had lots of cholesterol plaque within it, and as a complication of that procedure, he developed cholesterol emboli causing vasculitis, and all he required was supportive care to get better, and certainly not steroids and immunosuppressive drugs. Another example for audience response, I'll tell you up front that this is a 78-year-old man who came to us with this rash of palpable purpura. He also had polyarthralgias, mononeuritis multiplex, sensory motor neuropathy, and his past history is very significant because he had a coronary artery bypass procedure 6 years before. He was known to have diabetes and hypertension, and his labs at the time that this lesion was found showed a significant increase in liver enzymes. He had a positive rheumatoid factor, low complement, and had cryoglobulins of a mixed type, type 2, and he had a 5% cryocrit. So think for a moment what the underlying cause of this secondary form of vasculitis might be. And what tests might you want to get to determine whether or not this is Henoch-Schönlein purpura, viral-associated vasculitis, and what virus, or is this another paraneoplastic vasculitis? And so the test that we chose to do was to look for hepatitis C virus, because that is the most common cause of type 2 cryoglobulinemia and the most common genotype in the United States for hepatitis-associated cryoglobulinemia and vasculitis is genotype 1. He had a very large viral burden. He was treated with pegylated interferon and ribavirin. Like most elderly people, he didn't tolerate that very well at all, had to come off it, and he developed new-onset nephritis. His creatinine rose, and unfortunately, over the ensuing months, he died of multifocal ischemic complications of hepatitis C, cryo, and vasculitis. Now, let's look at this from, again, the perspective of the big picture like we did with cocaine. This is an incredibly common virus. 130 to 170 million cases worldwide. Global prevalence, 2% of all people walking this earth have hepatitis C. And not all of those people will develop cryos. The figures vary from about 40 to 60%. So you have hepatitis C, you have a unique capacity to respond to that hepatitis C. Some of you will make cryos and some of you won't. Well, what about the vasculitis part? Well, only less than 5% of you who will get hepatitis C will make cryos and have vasculitis. So there are a number of cofactors that we don't understand, that we don't have a handle on yet, that set the stage for getting cryohepatitis-associated vasculitis beyond just getting the virus. So this is work in progress. we would like to know what those cofactors are. The other thing to remember here is while this virus in some people stimulates a lymphocytic response in an attempt to clear that virus, which usually it cannot do effectively in most people, some people with chronic hepatitis C, even if they clear the virus with advanced therapies, will have continuing engaged lymphoproliferation, even perhaps not driven by the virus at that point, that accounts for this population having a 35-fold higher frequency of lymphoma than in the general population. So how would we treat it, even given the imperfections of treatment as it exists today? Well, pegylated interferon alpha is one of the foundations of treatment, hopefully soon to be replaced by other agents, plus ribavirin for a minimum of a year. That is the current standard of care and the standard to which other newer therapies are now being compared. 50% of patients have genotype 1 within the United States, and others have genotype 2 and 3. Genotype 1 is more resistant to this therapeutic protocol than is 2 and 3. What is considered a good response to this therapy is clearance of viremia for over 6 months after completion of treatment. The success rate is a little greater, about 80% with genotypes 2 and 3, but only about 50% with genotype 1 will achieve a 6-month response. There are the new viral protease inhibitors, and these have not been terribly well tolerated, but there are new products that are related to them that not only don't have to be given parenterally, but also given orally, and this is a rapidly evolving story. So this is a good juncture at which we can pause in talking about the difference and concerns that we have about once you make a diagnosis of vasculitis, understanding what is actually going on within the vessel wall, appreciating the differences within different vascular beds and different organs, and then also recognizing that it is your burden to distinguish whether this is primary versus secondary, and if it's secondary and there's a treatment for that cause, then to provide that specific treatment rather than inappropriately use immunosuppressive drugs. So when we start up again, we'll be talking about specifically those forms of vasculitis that are primary, idiopathic, and presumed in many cases to be autoimmune until we find out otherwise.